And so I think that we can turn it over to Carl and Kayla and get started.
Great, thank you, Amanda. And good morning, everyone. On behalf of the Colorado Healthcare Ethics Forum Board of Directors and our president, Amanda Hine, welcome to the COVID-19 Vaccine Equity and Rural Healthcare webinar. I'm Carl Middleton, your MC and immediate past president of the Colorado Healthcare Ethics Forum, more commonly known as CHEF. I have spent 45 years as a theologian and ethicist in healthcare. We are excited to have you with us today for this most informative webinar. Thank you for taking time out of your busy schedules to be with us. CHEF was founded in 1999, was originally under the CU Health Sciences corporate umbrella, but the CHEF nonprofit standalone organization was created in the late 2002. The CHEF facilitates clinical ethics education and networking statewide, and CHEF actively seeks out diverse perspectives and open dialogue on morally complex issues. Our core values are collaboration, diversity, wisdom, justice, and compassion. Our larger goal is to aid individuals whenever they encounter difficult healthcare decisions using a foundation of knowledge, compassion, and openness. Up to the pandemic, we hosted an annual conference for over 20 years where healthcare providers can learn and enhance skills needed to respond to today's challenging ethical issues. This year's conference is tentatively scheduled for Thursday, November 18th and Friday, November 19th, 2021. We hope and pray that the U.S. has achieved herd immunity and participants can attend in person, but put those dates on your calendars and stay tuned. Some important instructions for this morning's webinar. Your microphones will be on mute so that everyone will be able to hear and enjoy the webinar. Please feel free to ask questions during the panel presentations by using the chat icon. If you have a question for a specific panelist, please note that. This webinar will be recorded and available on your CHEF website and YouTube. Give us a few days to edit the recording. Now, it is my privilege and pleasure to introduce to you our facilitator for this webinar, Kayla Kostelecky. Kayla is president-elect for the CHEF Board of Directors and a CHEF board member. Kayla has a law degree from Chicago Kent College of Law. She has a PhD in healthcare ethics from St. Louis University, and she is an affiliate faculty member and teaches healthcare ethics at Regis University. And here's Kayla.
Thank you, Carl, and it's my privilege to welcome and introduce our panelists today. Theresa Trujillo is the Director of Community Organizing at the Center for Health Progress, with decades of experience in facilitation, community engagement, and campaign management. In her role as Director of Community Organizing, she works to organize the Pueblo community in which she was born and raised. She is passionate about power building in marginalized communities so that communities are able to advocate for the structural changes necessary for them to thrive. Building relationships with the local community, she seeks to empower those most impacted by health injustice and racial inequities. Theresa and the Center for Health Progress have been coordinating vaccine distribution campaigns in the local community in response to barriers to equitable access. Dr. Joel Tanaka is the Senior Vice President of Medical Services at Peak Vista Community Health Centers, which is a nonprofit, federally qualified health center operating clinics in the rural communities of Divide, Strasburg, Kiowa, and Lyman. Dr. Tanaka is a board-certified family physician and an Army veteran, retiring as a colonel in 2018. He is a graduate of the U.S. Military Academy at West Point and the Uniformed Services University of the Health Sciences in Bethesda. He serves on the El Paso County Medical Society Board of Directors. He is passionate about serving people who have access barriers, and he has been intimately involved in Peak Vista's vaccine distribution work. Josh Neff is the Vice President of Integration and Rural Health at Centura Health. Josh and his team work with over 16 small rural critical access hospitals across Colorado and Western Kansas to drive sustainable access to care, especially for those most underserved and marginalized in the community. He has over 20 years of experience with operations and progressive leadership at nonprofit, faith-based, top-ranked integrated delivery systems. Josh received his undergraduate business degree at Tarleton State University and his master's in administrative and organizational leadership at the University of Oklahoma. And Josh is a board member of Chef. And then we have Dr. Robin Johnson, who is the medical director of El Paso County Public Health. She has 28 years of experience in medical practice and healthcare advocacy in the Pikes Peak region of Colorado. She received her doctorate in medicine from University of Colorado and completed an emergency medicine residency with Denver Affiliated Residency. She also holds a certificate of medical ethics from Catholic Health Initiatives and a master in public health from the George Washington University. She serves as adjunct faculty for UC Health School of Medicine and serves on local boards in the Pikes Peak region, including the Community Ethics Advisory Committee. She chairs the Peak Vista Community Health Center's Board of Directors and the Behavioral Health Steering Committee for El Paso County, and she is also on the board of Chef. Vaccine equity in the most basic sense means that all people have the opportunity to become vaccinated, especially those populations that have historically and presently been disadvantaged by structural barriers to healthcare and other resources. Josh, given your work across multiple hospitals in the rural setting, what are some of the barriers to equitable vaccine distribution that you've seen in the rural setting?
Yeah, thanks, Kayla. The rural setting, and we'll talk a little bit about the distinction between what we consider rural and frontier, and I think it'll be pretty interesting to see people's reactions. So if you look at this particular map, those maps in kind of the medium gray color are actually considered rural, right? You wouldn't think that some of the areas out towards the 70 corridor or even up the 76 corridor, Morgan and Logan County, I mean, those are deemed rural. And our challenge in those communities is vastly different than what we see in what we call our frontier populations. There are significant access issues in both rural and frontier locations. We have a lot of miles between each of our hospitals. There are typically more livestock than human beings in those particular regions. If you look at this particular map, you can see that the majority of the hospitals are aggregated along the 25 corridor, and they're close to the 25 corridor. You get much more than about 20 minutes off the 25 corridor, and your access to healthcare is extremely limited. What we've seen in these communities is that because of the population and their remote nature, there are significant challenges. One, getting the vaccines out there, understanding how many folks in those communities are interested in having the vaccines. These communities are staunchly independent. They like to live out in the middle of nowhere on purpose and for a reason, and they're not early adopters of a lot of new technology in healthcare. So we see challenges relative just to the general distribution of the vaccine and the utilization and uptake of that vaccine. Some of the challenges we do have in those markets are the storage requirements, the cold storage requirements that each of the different vaccines have. You know, initially the Pfizer vaccine needed to be kept at -70 degrees, and the ability for us to have refrigeration and freezer resources to keep those vaccines at that deep level just didn't exist. And they're quite expensive. It's an $8,000 freezer for us to try to get into that market when we also don't have the buying power to do so. So as you get further off that 25 corridor, access becomes more and more challenging. There are fewer resources. all of those hospitals in the eastern plains of Colorado, let's just focus on that market for a minute. Those are all rural critical access hospitals, meaning they're all 25 beds or under. And the majority of those hospitals staff for 8 to 10 beds. On a good day, they'll have 3 or 4 patients in the hospital. On a busy weekend in the emergency room, they may see 7 or 8 patients. Typically, those patients are relatively high acuity, meaning they're relatively sick or they're trauma. Given the agricultural nature of a lot of these markets, there are some big injuries. Given that 70 and 76 and a couple other major highways run through there, they see some trauma. So these organizations are stressed relatively easy. So you add on top of that a global pandemic that requires us to think outside the box and move quickly, becomes a challenge for us relative to that vaccine distribution. Another important aspect of it is the actual vaccine distribution. The challenges in the rural market centered around our ability to know how many vaccines we were getting, how are we going to store them, how do we put that together, knowing that there are a certain number of doses in a vial. We certainly didn't want to waste any of those vials at all, and we'll talk about the ethical decisions that rural providers had to make, given kind of the any harm will do approach when it comes to making a choice between vaccinating someone that's not on a list versus wasting vaccine. So there were some significant logistical challenge as well in those rural markets.
Thank you. Thank you.
Yeah.
Oh, I apologize, Josh. Thank you so much for walking us through the logistical challenges, particularly from the perspective of hospitals distributing vaccines. At this point, I wonder if Dr. Tanaka, you might give us some perspective about what it looks like to deal with some of these challenges from the clinic level, working in the different communities that you work in.
Sure. Thank you. First, I'd like to actually also say thank you to Dr. Hind, Dr. Kostelecky, Dr. Middleton, the entire Chef Board of Directors for allowing the opportunity for me to be a part of this. It's pretty amazing. I love the work that your team does, and I hope to continue to be a part of it. So thank you. So you may look at the introduction that I had and go, what does this guy know about rural healthcare and what can he possibly bring to the table? And to my answer to that, probably about a year ago would be probably not much. And I'd have the same exact question coming out of the military after so many years and really dealing with a population of folks that I guess I'll say, for lack of a better word, really not wanting for much, because the DoD really does a great job of taking care of its men and women in uniform and their families. So fast forward, a couple of years later, after I got out of the military and was able to join Peak Vista as a federally qualified health center, whose really mission is to engage folks who have access barriers, which really speaks to a lot of the ethics that we're talking about today. But it really has been a great opportunity for me to humbly say that this team here at Peak Vista, out in the rural areas, out in Teller County and out in Lincoln and Arapahoe and Adams County, have just been phenomenal in terms of teaching me, what it means to take care of people in a community like that, unlike anything else I've ever experienced. So I'm thankful to the team being willing to teach me. So hopefully we'll be able to impart some things to those in attendance today, and hopefully we'll walk away with a little bit better understanding. I would say probably one of the biggest things that we learned early on, as far as the logistical aspect of it, is the whole idea of getting things across time and distance. Josh had mentioned the cold chain custody, and that's it's pretty significant, especially early on when there are very, very strict guidelines with regard to how we package, how we move, how we store, how we utilize these vaccines. And while, at least for us at Peak Vista, we're giving vaccines every day. I love the idea of primary prevention, so it's really exciting. So these additional unique features, more so out in the rural areas, were challenging because folks are used to doing it a certain way. And I'll just echo Josh's comment about the different cultures and really the being proud of the independence and wanting to be independent. You know, folks, in my experience, after being out there and communicating with the teams, they want to do things their way. And they've got hearts, you know, that are beating out of their chest. They're so big, and for love of community. So that can be, it's usually great, but it can be very difficult when you've got folks who just want to get the job done, right? They just want to pick up that box and go. And so we ran into some challenges early on with regard to that, you know, the lessons learned and trying to communicate across distances and communicate in a way that's well received, and the importance of these very important steps, because of this vaccine is so relatively fragile, for lack of a better word. Having folks that understand protocols, you know, it's there's nothing that can really replace or beat the face-to-face communication between leadership and between those who are executing a mission. Being in a rural setting and having that time and distance makes it very challenging to really get the message across, unlike many of the centers that we have here in El Paso County that we're able to, you know, get out to very quickly. And, you know, to me, as a leader, this is a lesson that I have to continue to learn over and over again, because, you know, heck, right now we're all talking to each other via this Zoom. So it's kind of face to face, but to me, really the lesson learned too is to be able to get out, get boots on the ground, talk to people, answer their questions, look them in the eye, and try to clarify things on the front end. Thankfully, we didn't lose any vaccine through any of those processes, but it was, you know, there were some nerve-wracking moments when we were engaged with the state, and so thankfully we didn't have any issues with that. I would say the other thing, as far as logistical, that's challenging and that has been challenged, is the dose management. So when you're in highly populated areas, you've got lots of people, especially when you're getting a vaccine that has 10 to 12 doses, you know, and you've got that time sensitivity once it's punctured. It's a little bit simpler to dose manage when you've got lots of people around. And again, I'll echo Josh's previous point about, you know, getting vaccines in arms became our priority as to not waste a vaccine, depending on who was around and whether they were eligible and didn't have any contraindications. So that is a challenge regardless of where you're giving the vaccine, but it was a more difficult challenge that we wanted to address early on. We found it was very difficult to do, and to my knowledge, we haven't lost any doses through that means either.
Wonderful. To that, you know, to that point about being kind of in touch with the community and working with the local community, I think, Theresa, you might be able to give us so much perspective about your work at the community level and some of the challenges, not only in terms of the rural community, but when you talk about specific populations in rural communities, for example, your work in Pueblo, what are some of the equity issues that you've seen regarding vaccine distribution?
So our work for Center for Health Progress, both here in Pueblo and the surrounding area and in Morgan County, up in the northeastern part of the state, I think that we've seen a lot in the last 2 months. We've been at vaccination for about 2 months now, maybe a little longer. And the process has been really exciting in a lot of ways. I mean, to be able to celebrate with folks who are getting vaccinated. We were so lucky to be able to work in the first month with the first wave of folks who were super eager to be vaccinated and so relieved to be vaccinated. And we're still seeing folks, even folks who might have more trepidation around being vaccinated. The process of being vaccinated is certainly a moment to celebrate and certainly a moment of great relief for folks. And so that's been really exciting and a really wonderful part of the work that we're doing. And we've seen a lot of things that are concerning about the evolving system for health equity and vaccine equity in particular. And one of our concerns is that we have these very well-funded and well-staffed mass vaccination sites, but often those are sites where there is a large law enforcement presence, because we have law enforcement who is not just paid to do their job of law enforcement, but is also often in a lot of counties the emergency management services. And that's a really hard thing for folks, and particularly folks of color, to make the differentiation about the role of law enforcement at different places. And now in Pueblo with the FEMA site, and we're so excited to have those resources, but the military presence can also be very much of a barrier for folks. And so what a lot of folks of color are relying on are these small neighborhood pop-up clinics that, you know, the state has set aside, I think it's 15% of the total number of vaccines for these pop-up neighborhood clinics that really can serve folks of color and harder to reach community members, and harder to reach because of all of the health equities that we face within our system, and disparate impact of a lot of different things. And so that process of figuring out how to deliver those vaccines to that population of folks really has fallen on local nonprofits. And it's local nonprofits who are already pretty extended. You know, they've really extended themselves in the time of COVID to ensure that folks are receiving the direct services that they need. And those are the folks who were super excited about putting forth the opportunity to be vaccinated, because they knew that they had reach into communities that the state doesn't have as much reach. And so, and they could really hold those trusted relationships as a means of doing the education necessary so that folks are willing to be vaccinated. But that system of providing the vaccines, but not providing any financial support, any infrastructure for those clinics to stand up in communities has also been hugely concerning. And it is an ongoing concern, particularly as we get to the point now where we've made our way through. Most of the folks who were eager to be vaccinated have found a neighborhood clinic or gone to a max vaccination site, and it's going to be harder now that we've reached that sort of 50% place. It's going to be a lot harder, and it's going to take a lot more accompaniment of individuals to get vaccinated, because it's often folks who have difficulty navigating systems or have been harmed by systems, and so have a lot of anxiety around that. And that work is really about those local systems. But the fact that we're not getting any government funding to fund those clinics, and that money is going into those max vaccination sites that aren't serving as many of those folks is really concerning. And so I think one of our concerns is ensuring that folks of color are included in this idea of herd immunity, and that the state is not just moving forward and determining that, well, if they don't get to every person of color, they can still get to herd immunity. We really need to advocate for our communities. And I think we really need to hold our government accountable for the means and the ways in which these clinics are being funded, and the resources are or are not getting to folks who need to be vaccinated. Oftentimes it's people of color, and we've done a lot of work, particularly with migrant seasonal agricultural workers who are coming into the area to work. And our commitment was attempting to give that first wave of folks who were eager to be vaccinated a good and positive experience, because we know that that's the message that they're carrying into their own networks and into their own communities about the vaccine. And so if we can give them the best positive experience possible, where they're not waiting for long hours, or they're not going to a mass clinic where the chances are higher that they're being asked for identification, or they're being asked for insurance and having to say they don't have that, or having to navigate a system where there's not language that they're comfortable with. And so there's lots and lots of barriers, and it really is our local nonprofits and some statewide nonprofits who are really filling that gap in a very significant way. But we have to keep looking at the fact that it's private foundation dollars that they're relying on. Those often don't meet all of the costs that they have. and that the state in particular has not stepped forward with funding for those entities to continue to do the work that depends on the deep relationships that they have in those populations.
And there's, you know, the infrastructure difficulties I think everyone is speaking to, and Dr. Johnson, you might be able to expand as well on what that looks like from a public health perspective, because the public health system has, you know, was already so strapped when COVID hit. So, you know, what are some of the challenges at that level, the public health system working so strained as well?
Absolutely. I think what we know about public health is that it's not created equal across the whole state. Each county has a very diverse response within that public health sector. And, you know, while El Paso County is vies with Denver for being the most populated county in the state of Colorado, we also are one of the lesser funded per capita, not like total, but per capita. And we have one of the larger geographic distributions. So we have a large municipal response in Colorado Springs, and that's where most of our resources lie. But we do have responsibilities out into the Eastern Plain and experience for a lot of our rural community. And then we serve regionally for Park and Teller and a couple other of our rural counties to facilitate when they need other resources or we have a regional response to something. What has been really key to public health response in this is the ability to set the table to bring partners together. And in the vaccine response, we actually created a consortium bringing together the trusted partners early on. And that included our 2 hospital systems that are in the Colorado Springs area, but also Peak Vista, Optum, Matthews VU, and then the federal response through our pharmacies. And that has been able to increase as our supply has gotten more steady. We had a 3-pronged approach, really leveraging those brick and mortar, but then the mass vaccination because of the sheer numbers that we could get out and recognizing that we had to have that approach of getting large numbers of people vaccinated, but then the equity piece, which Theresa speaks to so eloquently, around how do we assure that there is an ethical and equitable distribution to all of our population, whether that is to a population who are geographically isolated and have difficulty with access, whether it's because of social determinants, they don't have transportation, they don't necessarily utilize the platforms that we so blindly use in healthcare with EMRs and things. And so really beginning to work again on having set that table, bringing in non-traditional partners to bring the message, whether that's the Pikes Peak Library District, and we send the message out in the bookmobiles, which is really exciting. That was one of my favorite things as a kid. But also the YMCA and El Pomar's emerging leaders, trusted leaders in the faith community, and then bringing some of these out into the rural communities and really trying to hear what are some of those things that lead to being an early adopter versus having a little more trepidation and waiting to see if, you know, somebody thrives after their vaccine, bringing education and debunking the myths that have emerged. And I think that also combating some of the politics that have been brought to bear, unfortunately, and making sure that we just are very transparent and honest. And I think over the last year, what we've really learned in public health and having gotten to be the messenger of education is that this is an evolving process, right? It's a novel virus. There's still things that are very novel about it. And so how do we bring forward trust, transparency with the understanding this isn't necessarily binary. It's not just either or, it's an and both, and it's evolving. So there will be more information coming forward, which is exciting because we're learning more, and it's not so exciting because we're learning more. So those are some of those ethical questions that I think that we, really need to consider as we look at the diversity of our populations, whether it's demographics, geographic, race, ethnicity, education, all of those things brought to bear to meet each person where they are so they make some wise decisions about their vaccine.
And this,
I'm so glad, Robin.
oh, I'm sorry, go ahead.
I'm so glad you mentioned the novel nature of this, because that's what has us on our toes a lot. And we don't want to look back a year from now and say, wow, it is true that we vaccinated the mass majority of folks that we vaccinated in our well-funded, well-staffed clinics were not people of color, they were white folks. And the folks that we relied on volunteers for, that's how our folks of color got vaccinated. That stratified system of vaccine delivery is already present, and we're trying to draw attention to that now so that we're not looking back in a year and saying, wow, we should have learned from that. We can learn now from that, and we can do a better job at removing those barriers so that folks can be vaccinated.
Theresa, that's such a great point, because I think one of the things that we have known in particular is that there's some fragmentation in our healthcare system. And when you have such a profound opportunity to call it into the light, I mean, we have opportunities to respond in a unique way. We have collaborations. I mean, one of the things that public health has done, and I've had the privilege of being part of, is some of the innovative programs to move our community forward. And suddenly it's like that has occurred on steroids. Our consortium of vaccine providers allows us to set the table to call forward some of these issues and say, we need you, like we have this piece of it, you have that piece of it. We know that, the Payne Chapel has the population that needs vaccinated. How do we get there and make that happen? And those are the conversations that we need to have happen. And it not only is the relationship that you're having with the individual, but we need to draw our agencies, cross-agency, cross-sector into that relationship to address the issues that we know have been percolating and now are so visible to us as providers.
Absolutely. Thank you.
And there's something quite, sort of exciting to hear of this transformative potential to really make true change to some of these, systemic issues that just repeatedly disadvantage and marginalize certain communities of color. And we've touched on some of these different ethical concerns that are raised given this backdrop of health inequity. And I'm wondering if we could maybe explore that a little bit more. What are some of the unique ethical issues that have sort of emerged in this context, given the inequity of healthcare access in rural communities, and in particular for populations of color in those rural communities? What are some of these ethical questions that maybe trouble you or that you've encountered and are working through as you go through this process?
So I would say that one of the things in the rural community is that I think we have had a lot in the news around, the inequity based on being of different culture or different race and ethnicity, and yet this geographic change out into the rural area brings forward a lot of the same challenges. Whether it's additionally impacted by race and ethnicity, there is a different kind of cultural approach in those rural communities that when we come, from a medical perspective or public health perspective, we really have to come to the table and listen and hear what the language that is used and understand how that language impacts it, and begin to understand the stories that they're bringing from their experience that influence how they feel around getting a vaccine or trusting medical care or interacting with their provider, and what it would mean if they have to come all the way into Colorado Springs to actually get their vaccine rather than being able to access it from, you know, their local trusted pharmacy per se. And so I think that the onus on us as providers is to understand that even if we drive into a particular community and they look the same as something that we might encounter in our own personal setting, that they're going to bring, even based just on that geography, a whole different mindset and viewpoint.
So there are ethical concerns certainly around where money and resources are being spent. There are certainly ethical concerns around the vaccines themselves. I think there was a lot of the health equity plan of the state was based on the use of the Johnson & Johnson vaccine and the one and done dose. And there were a lot of plans laid on that single dose vaccine. And to be honest with you, I'm not sure we can make it back from this Johnson & Johnson pause. There already was a significant amount of Spanish language media about Johnson & Johnson prior to the pause, and we were finding it tremendously difficult prior to the pause to convince folks that the Johnson & Johnson vaccine was as safe as the other vaccines. And so that, on top of ethical concerns that religious groups had around the development of the Johnson & Johnson vaccine and fetal cells in all of the vaccines, all of those kinds of concerns, I think, those were held, I think, in a lot of positional leadership within faith communities. We did not hear those necessarily from people of faith on the ground. It was really more about the efficacy and safety of the Johnson & Johnson vaccine. And I'm just not sure that folks are going to make it back. And so how does that impact the plans that government has in particular about how those vaccines will get used, or how do their plans change now that they're going to need to provide options for folks? Because providing options for folks, and in places like Pueblo where there are multiple options available in any given week, that's a little easier to navigate than it is in more rural areas where they only have access to the big COVID bus that is only carrying Johnson & Johnson. And so we're going to be paying really close attention to what happens when the pause is lifted, and what does that messaging look like, and what do those options look like for folks in community. I mean, Robin hit the nail on the head. This is highly relational work. Mm-hmm. And now as we get into this, trying to get from 50% to 75%, the amount of work and effort and relationship and reliance on relationship in that part of vaccine delivery is so critical. And so how will those options be presented to folks is a question that we're going to continue to ask.
And this, this concern about the, in particular, the kind of a religious-based concern about the permissibility, the moral permissibility of some of these vaccines, in particular the J&J, given the relationship to development in some ways connected to fetal cell lines. Carl, I wonder if you might jump in and give us a little bit of insight about what the Catholic Church in particular holds, maybe some talking points, so that if folks encounter this concern about the moral permissibility of these vaccines, they can maybe help individuals understand what the moral issue is there with some of the vaccines.
Sure, happy to, Kayla. As has already been mentioned, there's 3 FDA-approved vaccines in the U.S. that have presented to us as having demonstrated their effectiveness and are available. That's Pfizer, Moderna, and Johnson & Johnson. But as you've mentioned, that Johnson & Johnson is on hold for further evaluation. AstraZeneca has sometimes been mentioned, but it's not been FDA approved for the US. The situation of Pfizer and Moderna, they used morally compromised cell lines. I should say neither Pfizer nor Moderna used morally compromised cell lines in the design, development, or production of the vaccine. A confirmatory test, however, employing the commonly used but morally compromised HEK293 cell line was performed on both vaccines. Thus, while neither vaccine is completely free from any connection to morally compromised cell lines, in this case, the connection is very remote from the initial act of the abortion. By the way, the cell line involved in the three COVID-19 vaccines, a cell line known as HEK293, has its origin in kidney cells taken from the body of a child aborted in the Netherlands in 1972. So this is extremely remote. In the view of the gravity of the current pandemic and the lack of availability of alternative vaccines, the reasons to accept the new COVID-19 vaccines from Pfizer and Moderna are sufficiently serious to justify their use, despite their remote connection to morally compromised cell lines. In addition, receiving the COVID-19 vaccine ought to be understood as an act of charity, and this is from the United States Catholic Conference of Bishops and from the Congregation of Doctrine of the Faith from Rome. Receiving the COVID-19 vaccine ought to be understood as an act of charity toward the other members of our community. And again, I quote, "In this way, being vaccinated against COVID-19 should be considered an act of love of our neighbor and part of our moral responsibility for the common good." Being able to respond, and so the Johnson & Johnson vaccine is more morally compromised. The HEK293 cell line in Johnson & Johnson was used in the design, development, and production stages of that vaccine, as well as for confirmatory testing. Some bishops may ask Catholics to avoid Johnson & Johnson vaccine if there are alternatives available. It may turn out, however, that one does not really have a choice of vaccine, at least not without a lengthy delay in the immunization that may have serious consequences for one's health and the health of others. In such a case, it is morally permissible, because of the lack of alternatives and the serious risk to public health, so it would be permissible to accept the Johnson & Johnson vaccine if that's the only alternative.
Thank you so much, Carl, for giving us some clarification around that issue, and hopefully that gives people some perspective about the religious objections, particularly from Catholic individuals to the vaccine. One of the other ethical issues, there's so many ethical issues as we've been touching on here, but one of the issues that I think might be interesting to explore was mentioned by Josh and Dr. Tanaka, and is related to this issue of we have general guidelines at the state level about how to prioritize who's going to receive a vaccine, and yet you're working under these conditions where it may be difficult to follow some of those guidelines. And so I'm wondering if you could kind of walk us through some, how you've seen that issue present and how you navigate that issue.
Yeah, thanks, Kayla. Dr. Tanaka, I'll take a quick stab and then kind of hand it off to you. In the first days of vaccine administration, our teams in rural Colorado and rural Kansas were strictly adhering to each state's guidelines around who can and can't get the vaccine. At the end of the day, we would find ourselves with a number of cancellations. And so we were sitting on 2 or 3 doses in a vial and we were winding down our day. And so it became a real challenge for us, even though we had a backup list of folks to call. It's a little bit different, as Dr. Johnson mentioned. You know, if you're in Colorado Springs, you can pick up the phone and say, can you be here in 10 or 15 minutes? Because we've got a little bit of time left on the vaccine's half-life. In the rural communities, on a good day, a lot of those folks have a 30-minute drive into town, and that's if they're actually in the car and headed that way. So we found it challenging because while we wanted to adhere to the state and federal guidelines, we found ourselves with actual live vaccine in our hand that we didn't feel good about because that vaccine was going to go bad. And so after probably 3 or 4 days, we just decided to say, listen, there aren't many folks in these rural communities who actually want the vaccine anyway. In a lot of counties in eastern Colorado and northwest Kansas, the vaccine rate is 30%. Even in our healthcare groups, the vaccine rate is barely double digits. I've got a hospital in a rural community, and the vaccine rate of the employees is only 7%, and not many others intend to get the vaccine at this point in time. And so we're forced with, we've got these 3 or 4 syringes that we've got vaccine in, and so what do we do with that? So 3 or 4 days in, we just opted to kind of take the approach of any willing arm is a great arm to put a vaccine in. And at the end of the day, from a global perspective, it all goes to building a healthier community, building herd immunity, and the potential for us to reduce outbreaks and spikes in small familial groups or local cultural groups. And so as an example, it's challenging for some of those folks who are seasonal workers and in agriculture to get off the tractor or come in from the field between 8 and 5 or between 6 and 6 when the sun is up to drive 30, 40 minutes in town to get a vaccine. And oftentimes those families, they may have 4, 5, 6 or more members of their family, and they share one vehicle. And the patriarch of the family uses that vehicle to get out into the fields to do work. So there were a number of challenges. So we just took the whole approach of, listen, if we've got a car full of people towards the end of the day and only one of them is 65 and up and multiple comorbidities, but we've got several folks rolling their sleeves up, let's give the vaccine because we're not willing to waste the vaccine. And we know that we may only have 1 or 2 chances to get these folks into town. So that's the approach we took. Our staff actually struggled with that just because they were concerned about getting in trouble from our state and federal government because we were violating the very, CMS and the Joint Commission. Those are kind of scary people for hospitals, and even more scary for rural hospitals. And gosh, what happens if somebody rolls up from CMS and sees us sticking a needle in a healthy 21-year-old's arm? So we struggled with that and had to have some big conversation around what's best for the community we serve. And so we kind of embarked on that journey. So Joel, your perspective on some of the work you all did in your counties?
Sure. I think maybe it's just my personality, or I'm more of a beg for forgiveness kind of guy. And so early on, and I love the point because our staff struggled with it as well. People are concerned about their jobs, are concerned about somebody coming after them. But I made it very clear. Everybody had my cell phone, anytime, text, call. In fact, I've gotten a couple texts since this meeting started from some of our vaccination sites regarding some issues. And so to be available and to give people that are administering the vaccine the top cover, to be able to go outside the lines, once they reached out to me and we've had a chance to discuss it. In fact, early on when we were at some of our rural sites, when folks people come in droves, and sometimes people were drug in by their spouse. However they got in there, we didn't really care. We wanted to make sure that we were able to give them the vaccine that they need. Now, we did it not as a walk-in. We did a lot of it as we had walk-ins, but we tried to, based on lessons learned from some other organizations, we wanted to try to stick with kind of an appointment system as best we could, so we can have an idea with regard to dose management, and not having people waiting in long lines outside, wanting to make sure that we're adhering to social distancing guidelines. And so, however, as far as dose management goes, people would no show, and we would try to keep a very, very close eye, and then just ask, can we give this to this, these two caregivers that don't meet the, the letter of the law, but yet nonetheless would pose an increased risk were they to contract the SARS-CoV-2 virus. So, and from my perspective, personally, I would make sure that when we went outside the lines, our MAs, I named them, and I would put in the electronic health record, I would add an annotation to say that, they talked to me, I approved it, and so they felt like somebody had their back. And if somebody came down on anybody, it would be me, as the Senior Vice President for Medical Services here at Peak Vista. So time and distance, I never wanted to be an issue because I want to be accessible no matter where I was physically. So that was a really, really big deal, that people feel the freedom, and so that nothing's going to come back on them. But I'm with you, man. Shots in the arm, get it, especially for people who want it, because to your point, that wasn't the majority, and still isn't in many cases. And so educating, meeting people where they are, and these are all lessons that, kind of fundamental care, fundamental leadership, fundamental just human skills we're trying to teach our kids, but really getting back to the cultural aspect of it, and getting an appreciation, listening, and the other thing that they taught me too is, for many times it's a process. Have a conversation, answer questions, be okay with them saying no, I'll think about it, and trying to avoid pressure or shaming, or any other things that probably would act as a continued, antagonistic, or to promote an antagonistic relationship. So, as a provider, I struggle with it because as a primary care provider, I struggle with people not wanting to get it just because of my understanding of the science and primary prevention. As a family doc, I hate to admit it, but not much we do in primary care is primary prevention. So here we have just a golden and wonderful opportunity, but not to discount the fears, the misconceptions, and somebody had mentioned it earlier, that the reasons, regarding political, sides of the fence that folks are on. So I think meeting people where they are, and planting seeds within the community of champions that have been vaccinated, that are willing to talk to folks, that are willing to share their stories, that are willing to say, yeah, it hurt, I had this particular, side effect, but at the end of the day, we're doing it for each other, and to maybe play or build on that sense of community. And some of the things that Dr. Middleton brought up with regard to charity, and it being for the greater good, and thinking outside yourself or the community. But those are real concerns. My Eastern Plains providers, and administrators tell me about folks that come in that just don't believe that the virus exists. So I mean, there's just some fundamental. I mean, it just but you never know that unless you ask them, you talk to me, you had a conversation. It's not mandatory. The vaccine isn't mandatory. And with regard to the vaccine not being mandatory, it makes me think of the confusion or the barrier with regard to what's an emergency use authorization, because oftentimes people just see that it's not approved. The vaccines aren't approved. They aren't, but they are authorized for utilization in this public health emergency because of this public health emergency. So just basic conversations, but you'll never know where people are unless you take the time to listen. And that's tough in primary care, for sure, but it's necessary. And ultimately, I think we're going to need to rely on champions within communities, whether it's a rural community or a Spanish community in Pueblo, or the different communities. I think they'll are better responsive to folks that they can relate to. But you got to be relatable.
And I think this has been just such a takeaway here is all of your perspectives, for me, really speaks to the importance of kind of a localized response, right? A community level responsiveness. And then at the same time, Theresa, you talk about, the real issues with resources not being directed to some of those community organizations, the nonprofits that are really important in you know, meeting the needs locally. So there is kind of that higher level, the policy, you know, how we're investing and all too. So you know, I wonder, maybe I want to leave time for questions, but what would be, what do we need to do as a society, as a community going forward to kind of fill those gaps, to make sure resources are going where they really need to for equity to occur?
Yeah, I think it's about a both and strategy. We need both the max vaccination sites. I mean, with neighborhood clinics, we'll be here another 3 to 5 years trying to vaccinate folks. But with these mass clinics, we can get to the numbers that we need. But those aren't enough in communities. And even these federally run sites that are now piloting and popping up, the further removed you get from the local community, the less impactful relationship is in helping folks make the decision to be vaccinated. And so, you know, it's a little bit of a catch-22. And so we need a both and strategy of approaching this. We need to ensure that the entities that have carried the water, particularly to get folks of color vaccinated throughout the state, are being compensated for the work that they're doing, or we're just going to leave communities more decimated than they've already become in the time of COVID. And so ensuring that those local nonprofits have the funding and the infrastructure and the government dollars to stand up those equity clinics and to do it in a way that continues to honor all of the things that need to happen at a clinic. Efficiency isn't always the very most important value in delivering a clinic. Sometimes flexibility and relationality, you know, being able to send somebody in with a particular special need that can be accommodated in a neighborhood clinic, but recognizing and valuing the work that those local nonprofits are doing with little to no financial and resource mobilization into them is really critical at this point, especially as we get to this next wave of folks that are going to need accompaniment, that are going to need that relationship to sort of carry them into a clinic. And recognizing that the more that we're doing to ensure that our systems are designed for folks who have traditionally been the most marginalized in our community, it isn't just about the ethics of what it means to serve that population. It means those systems serve all of us much, much, much better. And so there's a lot of self-interest for all of us in ensuring that systems are meeting the needs of our entire community.
No, I would add to that much of what we are able to accomplish is not, I'm a big advocate of braided funding streams, which really means it's not just the dollars that go, but the resources. And one of the things, you know, in setting that table to get the partners together is, again, if you have the access to the individuals because of those trusted relationships, to bring in, you know, like our Medical Reserve Corps, to bring those vaccinators to the table, to advocate for getting the, you know, vaccine brought in a timely manner and maybe stored by a partner who has the infrastructure of the freezer, so that kind of economic burden is not borne by one person. And again, I think that this just reiterates what we can do in collaboration, and particularly in some of those non-traditional collaborations that we really cannot do on our own. And we don't need to reinvent the wheel. We don't necessarily have to bring our traditional healthcare providers into some of these communities. When we have the nonprofits, we have the relationships there, we can bring the resources to those nonprofits and those relationships that exist, and do so pretty effectively. I think one of the challenges as we look at the ethics of, you know, vaccine is that it just emphasizes that we practice ethics every day in our choices. And with this particular pandemic, we have had, you know, the vying priorities of autonomy versus our civic duty, and then social distributive justice, and some of these terms that we use in ethics. But we are constantly, you know, getting the message out. To Dr. Tanaka's point, having conversations and really trying to listen and educate, and then having to let go when people's choices don't necessarily align with what we think science and our community needs, would really emphasize, and then come back with some increased understanding and potentially others to help to bridge those misunderstandings or fears and allay the anxiety. And so all the time as we look at this, we are making those kinds of considerations, which brings us back to why we have this conversation in the ethical realm. Because I do think it's just part of where we live and breathe every day, and it brings forward that we need to bring, that compassion and wisdom to our collaborations and to our efforts to really care for our community.
It's like a slow motion natural disaster. And so we have all of these learnings from other times that we've faced similar situations way sped up. And so what have we learned in those situations that can be carried forward into this? And what we know is that collaboration and working together is really key. And so local public health departments are doing an absolutely amazing job of bringing together the right people to be able to solve those problems locally in their own communities. And so we need to ensure that they have the resources, the funding, and whatever they need to continue to do that work. That's what's going to be the most important for us. And we need not be lulled into simply thinking in the moment. We have to look ahead. We have to look ahead to the tremendous amount of influx of money and resources that is coming through the Recovery Act into our state, into our counties, and into our municipalities. Who's making decisions about how that money is being spent, and who's getting resources in the community? Who is the decision-making body? Does that really reflect the community? We have an opportunity. This is such a tremendous opportunity. And I don't want us to look back 5 years from now and regret that we didn't take better advantage of the opportunity that was before us. And the opportunity is, how can we use this huge influx of money and resources? How can we use what's happening in policy spaces to really look at how systems are designed and how we can begin to remove these barriers and remove the disparities that exist that impact our health and that impact the health and well-being of our entire communities. And so the opportunity is here. We have to take hold of that opportunity, grab onto that, and we have to be looking far enough ahead to impact what happens in the future.
Yeah, I just want to, it's very, very powerful. I think that, with regard to the future, one of the concerns that I have that we see, and the statistics are bearing it out with regard to, chronic health conditions in our rural communities. And I mean, this affects, everyone really, but looking forward and how we try to, just mitigate, heart attacks and strokes and other things that we try to, with controlling chronic diseases and the morbidity and mortality associated with it during this pandemic. I want to share one thing too, that, we have a lot of really, really great individuals and groups and organizations doing just amazing work. And I would echo the previous comments. This is gonna, we're kind of in this marathon here, and folks are getting tired, and folks are holding, a mantle of care and getting immunizations out into, nooks and crannies in very small amounts, but still, every shot is important. We had a nurse that reached out to one of our this was in I want to say Kayla, reached out to a pharmacy, and they started getting names of people who were homebound, and in these rural communities, and they were setting up, schedules and using the pharmacy was driving out to people's houses, and you got to have a backup first thing in case somebody doesn't answer the door or whatever. But how do we, not to waste a vaccine. But people are being very innovative. Individuals and organizations are being very, I guess, collectively minded. I also want to mention too that, what Dr. Johnson said earlier, without any assistance from El Paso County Public Health specifically, and the consortium that she has put together in this area, we really wouldn't be where we are today with regard to our vaccination program. So the volunteers, they're real, they're wonderful. The folks that the people whose day job is to take care of primary care and do primary care and do primary behavioral health and dentistry, they have all been doing their part and contributing to this vaccination effort. But at the end of the day, the primary mission still continues and has taken a pretty significant hit. So including that in how we move forward, in particular in those areas that are geographically remote, these rural and frontier areas that where it was kind of baseline not as good as it probably could have been. So it's just been compounded. So appreciate all the comments, and the amount of teamwork is incredible. But I just get concerned about our folks' resilience over time and the toll that it's taking on them. And I think it can't be really, the answer is, are we going to get additional folks, additional funding? How is it going into these areas that are a little bit more remote?
Thank you, Dr. Tanaka. Josh, do you have any words as we conclude and then open up to audience questions?
Yeah, I just wanted to say that one, I appreciate the perspectives of everyone on the panel. I'm looking forward to the questions. One of the things that we're trying to make a shift of is really how do we build trust in some of the communities in the rural markets where they're predominantly Caucasian in those markets. So I'm a white guy. I grew up in a predominantly Hispanic community in deep South Texas on the border. There's so much that I love about the culture and the people, but at the end of the day, I'm still a white guy. And so it doesn't matter how much I try to work towards building trust with some of these communities, there's still going to be that barrier. So one of the things we're working on is really finding key community stakeholders that are connected in those cultural groups. And to use Joel's words earlier, to provide what we call top cover, and that's a total military thing. There's a great book out called Team of Teams by Stanley McChrystal that covers what providing top cover means, but it basically means, so in a couple communities, we've got a relatively strong Vietnamese community, a relatively strong Filipino community, and a relatively strong Hispanic community. I'm trying to seek out people in our hospitals who have connections to those communities and who align with those racial and ethnic lines and saying, listen, I've got your back. They're not going to trust me no matter what I say. If you can get people here, we're not going to ask for their IDs. We're not going to have to put them in our medical record and all of those things. If you can convince your folks in your community to get here, I've got your back, you've got their back. And so how do we just do whatever it is that we need to do to build trust so that folks will drive up under the cover of the emergency room, lean their arm out, and a minute later or so be on their way. So it's really important, I think, that we look at how we can be creative and keeping in mind in all of the ethical implications that are that fall into this. But at the end of the day, how do we really build trust and create connections with those communities where they're willing to come in? I honestly believe that if we can do this just through the COVID vaccine, that also builds trust for us to do bigger community health things down the road when we come out of COVID, when we need to be talking about diabetes and nutrition and heart disease and all that stuff, which are all important aspects of the totality of care that we need to be delivering in rural communities. So that to me is a big piece of what we need to be thinking about coming out of this as well, given that we've likely all stretched the boundaries of what our state or local government would consider guidelines to be ethical and to get shots in arms. So
yeah, I learned recently that the state is funding 100 influencers across the state. And I don't know exactly what that means. I'm hoping to follow up and learn more about that. I think that means social media influencers, but in small rural communities, that needs to look different. That could look like live individuals that are doing work in the community to be influencers. So I think there's all sorts of opportunities to really look at how we design systems around vaccines. I mean, we're going to need boosters. And so there's lots more coming up on the horizon. And I think it's so smart to be thinking about how does this impact other public health issues that we're working on? How could this be sort of a new way of how we tackle these other issues and these other disparities?
And I think, you know, looking forward and being hopeful about the positive transformative potential of the work that's being done is maybe a promising way to pause and open the floor for questions from the audience. We would love to receive any questions, whether you would feel comfortable submitting them through the chat box or would like to raise your hand or just jump in. I know the panelists would be delighted to engage with audience questions or thoughts. So here I see a question from Becky. She thanks everyone for your insights and valuable knowledge. Thank you, and I would of course echo that. And for any panelist, how do you balance individual autonomy of choosing whether to receive a vaccine or not, but also the ethical obligation of serving marginalized groups who are getting vaccinated at much lower rates? Thank you, Becky. That's a great question.
I think someone mentioned it here earlier, and it's I think a critical piece of that is approaching education and sharing information in a way that is not judgmental. Mm-hmm. For me and for our organization, for the promotoras that we work with across the state, it is often acknowledging that social contracts between systems and people of color have been broken in all sorts of ways, and acknowledging that there is reason to mistrust, acknowledging that people aren't crazy or not gaslighting people when they raise concerns about vaccination and they make ties to Tuskegee experiments, and they, you know, and so really being willing to have those really open and honest conversations with folks and willing to be vulnerable ourselves. You know, I'm very open in sharing with folks that this wasn't an easy decision to decide to get vaccinated. I had lots of concerns, but ultimately I'm vaccinating myself for my family. And it's about wanting to share space with them and share time with them. And I'm vaccinating myself for my community. And so really having those conversations with folks in a non-judgmental way and acknowledging what their fears are, whatever those fears are, no matter how far-fetched I might personally think those fears are, acknowledging them and being willing to enter into conversation about them and provide the space for that. That's why that relationality is so critical in encouraging this next wave of folks to be vaccinated. And it really hinges on our ability to enter those conversations free of as much judgment as we can muster.
And also being okay at the end of the day with what an individual's decision is. My concern is when I've had lots and lots of these conversations with employees here at Peak Vista and also patients, as I've had the privilege of being at several of these vaccination events and clinics. And ultimately, my concern is that people walk away with the decision not to, because I didn't do a good enough job of answering their questions or providing the information that they needed. Now, let's say I did, I still need to be comfortable and okay with that person if they decide for whatever reason, because Theresa, what you're talking about to me, you know, I think about motivational interviewing, and it's really kind of like, well, you know, you can do it. I may have a list of reasons that I think it's really important, but if what you value isn't on that list, then if I were you, I wouldn't get that vaccine either. So it's trying to understand how you mentioned family, you mentioned, you know, being able to socialize with your community, and that's what you value, and that's what drove you. And I think getting to the heart of what people value and how the vaccine, or at least how we feel the vaccine may benefit them to do what they need to do. You know, there was I heard a brief talk this morning on the American Medical Association, the website. There was a little little podcast or something that talked about the ethics of these vaccine passports, right? And the discussions that they're having in Europe and in other countries. And, you know, the whole idea of in individuals, and to get to the question, an individual's autonomy, you know, to decide whether or not they want to get the vaccine, but also balancing that with what we may or may not require in our communities. Like, you want to go to this, you know, concert, you're going to have to show that you've been vaccinated. And so the autonomy to get a vaccine or not, but the second and third order effects and the ethics of that in terms of the its effect on the people around you. You know, I thought it was a really great example of the licensing. They talked about it being a, you know, there was one, a digital health pass instead of calling it a passport, but also calling it licensing, like a driver's license. So you get a driver's license. Why? Because we want to make sure that you are safe to drive and that you don't harm people around you. You understand the rules of the road. And in the same manner that we want to make sure that when people are going out and being around other folks, that they are not posing unnecessary risk to themselves or to the people around them. So I thought that was an interesting conversation, but it certainly gets to the heart of that question in terms of, do we respect people's autonomy? And ultimately, you know, we require vaccines for schools and we require vaccines for, you know, K through 12 and colleges. And so it's you require it for the greater good and those things that Dr. Middleton had mentioned earlier. And ultimately the individual decision to maybe not go to college or maybe to not go to that rock concert is ultimately may come to that. So those are just a few comments.
Yeah, you know, this has been a vying priority to require vaccines or not. And I know that there are some that's required for travel, yellow fever, into certain countries where that's endemic. My son studies in the UK and he was required to have his meningitis vaccine before he could be accepted into the university. I mean, so there is some precedence for that. I think the main thing that I have learned in my advocacy around healthcare and working with some of our communities that have been more marginalized, and now being many times the messenger for public health about why our layered preventive health measures are so essential. It's the accumulation of our individual choices that create the community safety and health. And yet, this is something that I've spoken with our providers, and Becky, I don't know if this comes back to your question, but it really is, as individuals, about investing deeply and holding lightly. So while we pour our hearts into what we do and into educating and bringing our patients or clients along to understand and make wise decisions, we end up ultimately not in control of that and have to hold lightly and allow them to make those choices. And sometimes those consequences are not only borne by them, but they are, in this pandemic, they're borne by our community. We see that as we start looking at another wave here, that we are not, I mean, while we have vaccine and it's a huge tool in our toolbox of preventive measures, we are not at herd immunity yet. It is not a one and done proposition. Vaccine is truly a community effort. And so we still have a lot of ways to go. That light is at the end of the tunnel. The shore is on our horizon, but we still need to be wearing our masks and maintaining social distance and a lot of those other preventive measures until we get there, so that we are protecting each other and ourselves until we get to that point. So
we have a few more questions, and maybe we can circle back to the question of autonomy. But Don asked about pandemic. Well, he says pandemic fatigue is real. Now we're seeing COVID vaccine fatigue, with vaccine availability exceeding demand or desire for the vaccine in some cases. Dr. Johnson and others have mentioned trusted local pharmacies. Has this initiative helped to expand the penetration of vaccines?
Yes, in our community it has. And I think it's some of the accessibility, just that geographic location that you can, go in, and many of our pharmacies are located in a grocery store. And so you walk out, you buy your milk and get your vaccine. I think that there is something that normalizes that as well.
Yeah, so conversely, I think in the rural and frontier markets, what few people were depending on their local pharmacist thumbs up on this have gotten it. And I don't know that the position of the local health providers, be they physicians, nurse practitioners, PAs, and or pharmacists, at this point in time in the journey, I don't know that we'll continue to wave the flag, but we're not anticipating having folks really flip the switch and then start rolling in just because our providers have done that work already. And I think we've hit that spot for us. So a little different perspective from Dr. Johnson.
Thank you, Josh. And then we also have a question from Oswaldo. Given the importance of community leaders within more rural areas, would it be possible for local governments to strengthen their relationships within these communities without compromising a community's cultural identity in the future?
Yeah, so I think that may go back a little bit to Theresa's point earlier relative to finding key stakeholders or cultural influencers in those communities. I think that when I think across the eastern plains of Colorado, western Kansas, the multitude of hospitals and communities that I work with, there's not a lot of diversity. Your county commissioners are not typically of diverse backgrounds and populations. Your hospital board, there's just not a lot of diversity, and that continues to break those trust barriers, or at least continue to be a barrier for building trust with those communities around cultural identity, whether we would consider them marginalized or not. And so I think it's going to take a lot more work to really understand how we approach that in these rural communities. And it's something that my team in Centura is kind of scratching our head on today, just because we know that we need to be able to reach those communities and provide care across the board specific to COVID for this discussion. But that is a big challenge. And having people come to the table, open-minded, transparent, authentic, being willing to accept and appreciate the differences of everyone in the community and the power that bringing those differences have in terms of building a vibrant and thriving community that addresses the needs of the whole person, of the whole community. That's a big, big challenge.
Yeah, and I would say that it's important to recognize that some of these communities, we've had the opportunity to work with schools from the public health department. I mean, we work with them on safety measures and how they implement those, and each school looks different. So while there are certain principles that we need to apply that might be varied based on their school, and you take that from an urban school into the rural school, and it looks even more different. And a lot of these schools are also a social safety net for these kids. They're providing meals and reporting and their trusted adult relationships. And we were able to bring out our rural superintendents into a separate group because we weren't hearing from them in the larger group. And we knew that there were different challenges when we would have an outbreak or different things. And to hear them and their perspective, and then to bring forward leaders that they trust and that they can relate to is really important. And I grew up in a small mountain town in Idaho, so I kind of thought I had some real understanding, having grown up in that environment, logging and farm community, and yet that is not how I'm viewed, and that matters. Their perspective is essential, and those relationships we are able to leverage leaders that can bring that message home in a very different way. And again, it comes to being humble enough to admit that while I think that I have some understanding, it needs to be from someone who they know has that understanding.
Yeah, it's interesting that you bring up schools. We're very much seeing on the ground now that there's vaccination happening of to 18-year-olds, we're seeing a number of students self-identify as the first person in their family to be vaccinated. And I think they will really, and they see vaccination as a key to opportunities in the future. And their other family members may not see that as clearly. But I'm also wondering if we'll see a vaccine readiness within families that is really spurred on by young people and their opportunity to be vaccinated.
Thank you so much for those wonderful questions. And I think, Carl, you have some concluding thoughts, but just personally, I want to thank our guest and thank the panelists, not only for being here and for all of the conversation in preparation, but also for all the work that you're doing during this past year, particularly in your communities, to make vaccination available to people, and all of the thoughtfulness. Just really grateful for you all.
I just, on behalf of the Chef Board of Directors, I want to thank Dr. Kayla Kostelecky and for her excellent facilitation of today's webinar. I also want to thank our panel, Theresa, Trujillo, Josh Neff, our board member, Dr. Robin Johnson, a board member, and Dr. Joel Tanaka for their outstanding work this afternoon or this morning in this webinar. We thank each of you for taking time out of your busy schedules to be with us. And for those friends and colleagues that were not able to participate in this morning's webinar, the webinar has been recorded and will be available on our Chef website and YouTube. You need to give us a few days to edit the recording. Because we've not been able to do our annual conference over the past year due to the pandemic, we have started then doing bi-monthly webinars. So we ask you to stay tuned for our June webinar that promises to be as exciting as this one. And also, I would be remiss if we didn't thank Dr. Amanda Hine, our president, for her work behind the scenes with giving us her technological expertise regarding recording this webinar. And so thank you, and we hope that each of you have a great remainder of your Thursday. Take care.